the field, we talk about exposure management, managing the exposure, reducing the exposure. Exposure is what produces the health. Exposure is what you measure literally right out in the person's breathing zone, if you can. And when you do that, you get a very different picture, as I say, a different landscape of control measures, a different landscape of sources. Now, let's see if I can get this other part going here. Okay, so you've seen this graph or something like it. India has the most polluted cities in the world. Of course, as we all know, this is, depends on which monitors you look at and which exact periods of time and how you weight the different monitors. I would say you can't really tell a difference between those cities in terms of the pollution, but these are very high levels. Reminder, this is small particles, PM 2.5, and the WHO says it shouldn't be more than 10 average over the year. The EPA standard is 12. European standard is 20, the Indian standard's 40, well above what would be considered healthful. Now, you may have, I happened to be in China when this came out by WHO, and people noted in China, well, China is no longer on the list of the top 20 dirtiest cities in the world. China must be doing better. No, it didn't mean China was doing better. It means they were finally measuring in places in India where they hadn't measured before. So this illustrates the point. They're starting to measure well in some of the smaller cities, not just in the big 4 cities in India. So, of course, they're finding a lot of pollution in those smaller cities. Well, what does this imply over time? Over time, as you start measuring more and more where the people are, you're going to find these pollution levels in even smaller cities. And in fact, you'll find them in rural areas. India has very high outdoor air pollution levels in rural areas. Why shouldn't it? It's got brick kilns, it's got household fuels being burned, it's got the pollution coming from cities, it's got power plants, it's got agricultural burning. There's a lot of air pollution in rural areas as well. Now, this conference is about cities, so I won't talk about that much more, but nevertheless, India is still breathing mostly in rural areas. 60% of India is still rural, and most people are breathing there. And they're not only breathing indoor pollution from household fuels, they're breathing a rather substantial amounts of outdoor pollution. Pollution does not pay attention to political boundaries, and you can't control it very well by just considering political boundaries. The pollution comes into Delhi, it leaves Delhi. Delhi itself has control over some of its sources of pollution, but not all of them. Other countries have found, in Europe and the US, is that regional solutions are needed often for air pollution control. In my part of the country, we have the Bay Area Air Quality Management District in Northern California. It has jurisdiction over 26 cities. It can fine any one of the mayors of those cities for not reaching pollution. It doesn't matter that we don't have much air pollution in Berkeley because our pollution goes downwind, affects people downwind from us. So we have to control our pollution, not because of our own pollution exposure, but because we're causing it for others. And every place around the world eventually is learning this lesson. This is true in China as well. Beijing does not have its fate in its own hands. It has to look at the entire region. So India does, however, have a lot of outdoor air pollution, arguably probably about the highest in the world, although I don't know that exactly. It also has some of the worst indoor air pollution, or rather household air pollution from solid fuels. In 1990, about 85% of the population was using solid fuels. That was 700 million people. Today, it's only 60% of the population, but that's still 700 million people. And indeed, in 1980, there were only about 700 million people. In other words, this problem is not going away. Sure, there are more people using clean fuels in households, but there are just as many using dirty fuels. This is something different. This is not what happened in the United States and Europe. As development occurred, the number of people using solid fuels in households went down and down and down. Not just the percentage, but the number. In India, there seem to be about 700 million people caught in what we've called the chula trap. They're still using these fuels. That's about 1/4 of the world's total. Here is what, these kind of situations like. I always show this picture in my lectures because it was you can see we're measuring her personal exposure. There's a pump here. It's drawing air through this filter. It's right in her breathing zone, getting a very good picture of what her personal exposure is. This was more than 30 years ago in Gujarat, and that was about 500 micrograms for 24 hours. So remember the city in the cities, the worst cities in India were about 150 micrograms. This woman is getting 500 micrograms. That was the first study ever done. We've done hundreds of other studies, measuring hundreds of other, thousands of other households, very similar levels found. So this is a very large population getting very high exposures to a pollutant that we know is health damaging. As a result, India suffers from a lot of both kinds of this in terms of ill health. This is the number of deaths, household air pollution number 2 after high blood pressure in the country, ranked as the total number of deaths. Ambient air particle pollution is about 6 lakhs per year. This one is not going up, but it's not going away either. This one is rising, as you can expect, as the outdoor air pollution rises for more of its population. If you want to look at in terms of lost life years, which is a better measure, household air pollution is number 3, and ambient air pollution is here. These are the diseases that we think are caused: the chronic respiratory disease, cardiovascular disease, and pneumonia in young children. Similar set of diseases for both types of pollution, exactly the same kind of diseases that are caused by smoking. These are all combustion particles. They all cause, each of these cause the same amount of pollution. Of course, nothing is as bad as sticking the stuff in your mouth, but it's not so great having a lot of it burning in your kitchen, and it's not so great having a lot of it burning poorly in your city. These two together make air pollution, not counting smoking, just the two types of household and ambient, together make it the largest single risk factor in the country for ill health, and the largest burden in the world from air pollution of any country. That is a health burden. Now, this evidence is based on very new, well, not so new, in the last 5 years or so, so-called integrated exposure response curves, where they've taken evidence from the different types of combustion particles. So outdoor air pollution, secondhand tobacco smoke, household air pollution from burning solid fuels, and active smoking. A very big difference in exposures, but the same kinds of diseases. And you put these studies together, and you get a monotonic increase in risk with increases in exposure. It's greatly informed our understanding of the health effects. We have them now for 5 major diseases. Bolsters evidence base overall, and of course allows for consistent comparisons, like I showed with those bars. Those are now consistently compared. So here's the one for ischemic heart disease, one of the major outcomes from air pollution. This is a single curve here that shows the amount of air pollution going up. Sorry, this should be micrograms per cubic meter annual average, and this is the relative risk, how much extra heart disease there is. So this is 30% extra heart disease, 70% extra here. These studies are the ambient air pollution studies, done mostly in US and Europe. These studies here are secondhand tobacco smoke studies. People living with a smoking spouse or children living with a smoking parent usually. The smokers are off the chart here. They get very high doses, but this curve will go out to their doses here. And then the household air pollution levels are around in here. Now, India's worst cities are up in here, although its averages are down in this area. And you can see a very consistent increase in risk with higher exposures to combustion particles. We have this information for stroke. We have it for chronic obstructive pulmonary disease. We have it for ischemic heart disease. We have it for, this is lower respiratory infections in children, pneumonia in children, and we have it for lung cancer. So these are the big 5 diseases. They're all big diseases in the country. Of course, there are other risk factors for them, but air pollution is one of the major risk factors. Now, people ask sometimes, well, but these diseases, these risk factors act together. Do they just add together? Well, not quite. Here is the total, just an example, the ischemic heart disease for females in India. And this is the total here. And tobacco smoking is responsible for that. Household air, that includes the secondhand smoke from women receiving the smoke from their husbands. And this is the household air pollution portion, and this is the ambient air pollution portion. And you can see they do overlap. You can't just add them together, but we understand, we think about how we can add them together and to look at the entire risk. So what do you compare? And there's no such place in the world with 0 air pollution. So the expert groups that did this chose for ambient pollution, they chose the 98th% cleanest city in the world. It was about 7 micrograms per cubic meter, below actually the WHO level. And so in the household air pollution group, we tried to choose something similar to cooking with gas, which would be about 7 micrograms per cubic meter. So the two are consistent. Now, you might argue that maybe the world could get down to less than 7. It's hard to see, sitting here in Delhi, how that would happen. Or perhaps you give it up and only go down to 40, the Indian standard, but you get a different result when you choose a different thing to compare it to. So, now another issue is that household air pollution and ambient air pollution, which are both prominent in India, are linked. This is the outdoor emissions from residential sources based on NASA data, and you can see a very high fraction of the particle emissions in India come from households, also to some extent in other places. We published a paper on this recently, and the estimate was about 25% of outdoor air pollution in India comes from household sources, mainly cooking, chulas cooking with biomass. Now, this is population weighted. It doesn't count the pollution out in the middle of the Rajasthan desert. It's weighted by where people are living. Now, we thought 25% was high, but a relatively recent paper came out in Nature, and they estimated 50% of the ambient particle air pollution in India comes from households. Even more recent data by Dr. Gudukunda, a prominent air pollution scientist here in India, and this is his fancy website. I just chose, he's got it by state and by actually district in the state, so I just chose more or less random place. Bihar in this area, and here you can see in that district, he estimated that 38% of the outdoor air pollution came from households, and his estimate is 30% global and nationally. So we estimated 25, he estimated 30, the other one estimated 50. I don't know what the right answer is, but it's a big number, meaning that you cannot deal with the outdoor air pollution in this country unless you deal with households. You also can't deal with it unless you deal with vehicles, and the power plants and garbage burning and all the other major sources of outdoor air pollution. But people tend to forget that that's why I don't like the word indoor. It implies that when it goes outdoors, it's gone. It doesn't gone. It becomes part of general outdoor air pollution. So the percent varies. As I say, the different models come with different answers, but the important point is that it is an important sector. It has to be considered together. Now, are things getting better or worse? I'm not going to get into this in detail, but here is an estimated total number of deaths from all kinds of air pollution in India, and you can see it's steadily rising. Now, hard to predict the future, of course, but unless trends change with major interventions of both in the household and the ambient sector, these are going to continue to rise. One difference that's not buried in here, it's less and less affecting children, it's more and more affecting adults. That's because India is doing better at protecting its children with better nutrition and health care. But of course, it's got an older population that's also burdened with other types of risk factors for the chronic diseases. So, there's a phrase called the environmental risk transition, and it asks how do environmental and health risks change during economic development? And India is in a very particular situation in this regard. It's not uniform in every country, but broadly is the case historically. So, and India is a unique place historically. So the idea is that there are a set of traditional environmental risks that tend to decline with economic development. Household air pollution from solid fuel use, dirty water, poor sanitation, these kinds of issues tend to decline with economic development. At the same time, there's a set of modern risks that tend to rise, at least initially, with economic development. Outdoor ambient air pollution in cities, traffic accidents, garbage dumps, toxic chemicals, agricultural chemicals, and so forth, they tend to rise. Indeed, the increase in the economy that helps provide income that may reduce the traditional risk also has, side effects of increasing modern risk. So this is the transition between traditional and modern. Actually, the full transition looks like this: household sanitation or household air pollution, the rise in urban air pollution and other urbanization and industrialization issues tends to rise and then fall. In rich countries, or way down here, they've conquered both. They've conquered household sanitation, they've conquered urban air pollution comparatively. There's a third category, a postmodern risk, you call them, greenhouse gases, and of course we haven't conquered that. The rich countries are producing more than poor countries, and that curve has not turned over. We hope it will turn over, but it hasn't yet. So this is the full transition. Traditional risks, modern risks rising and then falling, and then the postmodern risks, the global risks rising. India sits right in the middle. It's got some of the worst urban air pollution in the world and a lot of remaining traditional pollution at the same time. So it's in the worst kind of the risk transition period, the risk overlap, when there's a lot of remaining risks of both kinds. What India needs to do is to accelerate the natural decline of household risks, which haven't been declining in absolute terms in India, 700 million still stuck there. At the same time, blunting the rise of this, preferably cutting through this so you get down on the other side. If not, the burden is going to continue to rise. So, still 2/3 of households using solid fuels, only partway down the traditional curve. Most polluted cities in the world, peak of the modern risk curve. Highest burden of disease in the air pollution, from air pollution in the world. But of course, India is a big country, but it also has nearly the highest burden per capita. It's twice the burden of capita of China. So air pollution, I don't know what constitutes a crisis, but it sounds like a crisis. The largest single risk factor in the country for ill health, more than twice the burden of other big middle-income countries, stuck in the Chula trap, and still rising sources of outdoor pollution as development occurs. Now, India, though, has done something about this. The unique thing, as far as I know, pioneering. Just recently, the Ministry of Health and Family Welfare released this report. Anamita and I were both I was an honorary member. Anamita was a real member of this committee, and a number of other experts around the country. It's unique. Why? There are lots of studies on air pollution. Why is this unique? As far as we know, it's the first Ministry of Health in the world ever to pay attention to air pollution. Lots of places in the world pay attention to air pollution, but they're usually done by environment ministries. Just like here, the Ministry of Environment and Forests handles air pollution. In my country, the EPA handles air pollution. Now, they may say they consider health, but not in the same way a Ministry of Health does. Ministry of Health looks at all the risk factors for health, the need for vaccines, the need for better hospitals, the need for clinics in rural areas, and the huge range of things that affect health. First ministry actually to bring in air pollution, to look at that. Quite appropriate in India, because India has such a huge burden from this thing. Their charge to the committee was not to look at it by location, not indoor, not outdoor, not urban, not rural, but by exposure. What actually affects people. Again, as far as I know, no government agency in the world has ever given that charge to one of its committees. So unique in two ways. Not just indoor, household, or outdoor, but what would give the most health benefit? So the premise is, eventually we wish to control all air pollution sources, all the time, everywhere, right? But we can't afford that this year. How do we choose the best pathway? What metrics do we use to choose the best pathway? So at the end of December 31st every year, we go to bed knowing that we've done the most possible with the resources given to us. How do we measure that? So I said all this. What is the optimal pathway? Only metrics of exposure are capable of doing that, really, because exposure metrics are most closely related to actually ill health. So this is the classic environmental pathway, as it's called. So the source may, in this case, is sort of oriented toward household sources, but wood maybe as a source of pollution, but the emissions give you a better number. Concentration maybe in the kitchen might give you some better number. A best number in terms of actual exposure, because the women don't spend all day in the kitchen, they move in and out, is their actual exposure. Maybe you have something to measure in the body that would give you an idea of what their dose is. Really what you're after is health effects. But if you wait till health effects occur, it's far too late. You want to understand this pathway and intervene where you can along this pathway to prevent the health effects. By the time the health effects occur, the only thing you can do is call the failure people. Who are the failure people? Yeah, failure people are the doctors who cure you if you're sick. So exposure is the best metric. So source exposure relationships, the power plants produce emissions that produce exposure, but so do vehicles produce emissions that produce exposure. Vehicles tend to be a lot closer to people. The efficiency of producing exposure is much higher with vehicles as it might be with stoves. So to treat power plants and vehicles and stoves the same would be to waste money in terms of exposure and reducing health. If you spent the same amount of money controlling emissions here, you would be putting too much money into power plants, at least this year. Eventually you want to control them too, and not enough money into stoves and vehicles. And it makes a big difference. I'm going to move ahead here because I'm running behind. There are different ways to determine exposure. There are intake fractions, a population actually measure personal exposure, like I showed in that picture. Other modeling techniques to get at exposure. Many new tools available, including sensor network, satellite observations, GIS mapping, and small, cheap monitors, as Sunita mentioned. One approach is to intake fraction. The idea is the fraction of material emitted is actually breathed in by somebody. The worst intake fraction is this one. All of it goes down your throat. Fortunately, most of the things we worry about aren't like that, at least in environmental health. Here's intake fractions as calculated for Chennai in the Ministry of Health report. So here are power plants, in relative terms, this much goes down people's throat per amount of emitted. For waste burning and vehicle exhaust, 10 times more. Households, 8 times more. So when you weight these different sources by their intake fractions, you get a very different picture of what's important. So here is Chennai emissions, and vehicles are pretty important for emissions, but they're even more important in terms of intake fractions. Households go up too. Households, people don't use a lot of solid fuels in this particular city. It would look different for other cities. In other words, you get a much more targeted control landscape when you use exposure, and there are techniques now available to do it. Let's skip through this. So, how difference does it make? It makes a lot of difference. Actually a factor of 100 or so. Some sources are 100 times more dangerous per unit emissions than others. Why not control those first? Why worry about indoor, outdoor, rural, urban? Just look where the people are and control the things that affect what people breathe. So, integrated exposure allows more nuanced and efficient air pollution control. So, India's situation today is not like Europe and North America in the past. Traditional and modern sources both strong at once. 700 million people still using chulas, and yet you have, millions, tens of millions, soon to be hundreds of millions of dirty vehicles. Population density is much higher. We have 10 times the population density in India than we do in North America. In India, in the 1850s, who cared if you had a chula that was producing smoke? Now it pollutes the entire country when you have 700 million people using chulas. It's true around the world. What was possible in 1850 at low population densities is not possible today, and still protect health. We forget that side of the population problem. It's not really population, it's the fact that we have a finite planet and finite land area, and consequently, we're much more dependent on our neighbors being clean than we used to be. Traditional, modern, intermingled. Understanding of health effects has changed. Scientific methods have evolved. We now have techniques that allow us to pinpoint both the health effects better and also to do these kinds of exposure monitoring situations. So, not only the highest burden of disease, but also among the highest burdens per capita in the world. Get worse if present tense continue. Both ambient and household pollution are important, and they are connected. New approaches to control needed, and they are available. So thank you very much.